On behalf of Dr. Nagamani and Dr. Rauch, my co-chairs, we are absolutely honored and delighted that Dr. Lena Lande Wekre will be joining us today from Norway. This is a topic near and dear to our hearts for those of us in the OI world. Dr. Wekre is a senior consultant and chief physician at the TRS National Resource Center for Rare Disorders. This is part of the Norwegian National Unit on Rare Disorders and is located at the Sunes Rehabilitation Hospital just outside Oslo. She's working with the skeletal dysplasia team and did her PhD in adults with osteogenesis imperfecta. We're really honored to learn from Dr. Wekre as she works with patients with OI of all ages, from newborn to death, and all folks with a rare skeletal bone disorder are welcome to register at the center. Dr. Wekre has also been involved in developing a national registry for rare congenital bone disorders and is on the medical advisory board for the OI Federation of Europe, as well as the Norwegian Association for Osteogenesis Imperfecta, NFOI. Without further ado, please take it away. We are honored and really can't wait to hear about this topic. Please hold on to your questions. You could type them into the chat during the talk, and we'll get ready to talk about them afterwards, or you can hold on to them and unmute at the end. Thank you so much.
Oh, thank you so much for this nice introduction. And thank you so much for giving me a new opportunity to give a presentation about pain in OI. First, I have to apologize that the presentation that was supposed to be in December had to be postponed. However, I took the opportunity to gain a little more realistic experience, actually. I broke my ankle and had surgery on the day that the presentation should have been. So the experiences I gained during the 8 weeks, I wasn't allowed to step on my foot for 8 weeks. And I think I got a lot of experience that was not very good. So perhaps I can use it in this context or something like that. Next. I have no disclosures. I have to say that this build is from Montreal and the Montreal Modern Museum, the one behind the disclosures, no disclosures. The agenda for this lecture will be a short presentation of the center where I work. It will be some definitions of pain, some results from the global impact study that a lot of you know, which has given us important information about signs and symptoms in OI, some results from the Norwegian study, how to deal with pain, and some examples, and in the end, a short summary. As Jean said, TRS National Resource Center for Rare Disorders is situated on a peninsula, a short trip with a ferry just outside Oslo Center, and connected to Sunnaas Rehabilitation Hospital, which is the largest rehabilitation hospital in Norway, and also in Norden, I think. And we are a resource center for connective tissue disorders, like Marfan syndrome, Leigh-Stevens syndrome, Ehlers-Danlos syndrome, and for the skeletal dysplasias, and for arthrogryposis multiplex congenita, and for myelomeningocele. So several disorders. And we are also a part of the European Reference Network for Rare Bone Disorders. Next. The main tasks as an advisory unit on rare disorders, a few words about it. TRS is designed to supplement, not replace, the ordinary healthcare system and social services. And the diagnosis is the admission ticket to use the services of the center. And we are multidisciplinary. No, not this one. We build and spread knowledge about the rare disorders. And we should also monitor and disseminate information on new treatment. And we participate in research and research networks. We try to educate professionals and patient organizations and society about the rare disorders. We provide guidance and advice for main public services. We also provide equal access to services for people with rare disorders across geographical distance, socioeconomic status, age, gender, and background. And we are supposed to implement national guidelines and also international guidelines and experience-based knowledge to the different healthcare systems, and establish professional advisory boards and committees. And we are multidisciplinary. We have psychologists, occupational therapists, physiotherapists, social workers, special pediatrician, and medical doctors, of course. And we do also arrange a lot of courses for parents with newborn children. We have before school start to learn everyone about the disorder before the child start at school. We have courses about transition, about aging, and so on. And we do also have a lot of video conferences with to inform schools and kindergartens and local healthcare professionals about the diagnosis. And as you can see here, we collaborate quite closely, especially with Oslo University Hospital, but also with the other university hospitals in Norway. Unfortunately, we are not allowed actually to follow the patients at the center. So we try to participate in as many clinics as possible, and we collaborate closely with the university hospital, and also with the patient associations, of course, especially with the Norwegian and the European OR organizations. Then the next one. So, International Association for the Study of Pain, IASP, defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And we have three main phenotypes. Is the nociceptive pain, which is pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors or pain receptors. And then we have neuropathic pain, which is pain caused by a lesion or disease of the somatosensory nervous system. And at last, we have the nociplastic pain, and that is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage. And this pain is presenting in a non-neuroanatomical plausible distribution. Next. I think that a lot of you have heard about the impact study and probably also participated in the impact study, but a few words, because it gives us a lot of information, and especially about pain and fatigue, which is some of the problems we are going to deal with today. The impact survey represents the largest ever self-reported data set on OI, and as you can see, it's data from close to 3,000 individuals, of whom 2,312 had OI. And both caregivers with OI and those without OI provided information about their caregiving experiences and their recipients. And most responses came from people living in Europe, 45 to 88%, and North America, up to 25%. And the survey includes a broad representation of different OI severities and OI types, with most respondents diagnosed with type 1, type 3, and type 4. And self-reported OI severity levels were categorized as mild, moderate, and severe. Next. And as you know, pain is highly prevalent in adults across the age groups. And in the age group of from 18 to 30 years of age, about 80% says that they have pain. And in the group 61 to 70 years, 91% says that they have pain. So it's a big issue in the OI population. This slide shows an example of the data collected by the impact survey, and these are the signs, symptoms, and events in adults with OI over the last 12 months. The most prevalent Symptoms, as you can see, is pain, fatigue, and soft issues. And this graph shows also the complexity of the disease beyond the bone health, I think. For example, as you can see, the blue signs, the mental health problems is a big issue, with 41% describing that they have mental issues. And then you have gastrointestinal or stomach problems in 35%. And that's also a big issue, more than fractures even. If we go to the next slide. If, however, we look at how the various symptoms, findings, and events affect the lives of those with OI, we see that the problems individually have a relatively large impact on the person's lives. So even if only a few persons says that fertility or reproductive problems is an issue, it has a huge impact on the lives of those persons, like the fractures, like the mental health, and so on. And pain impact is slightly higher in adults with more moderate to severe OI and with increasing age. And then a few words about a Norwegian study that we did some years ago. At that time, the Norwegian adult study was carried out. Short form 36 was one of the most used instruments to survey quality of life. But today we use PROMIS, and we also use PROMIS in the registry, like the Key for OI, those who use Key for OI. 99 adults with an average age of 44 years participated in this study. 50% women and 50% men. That's quite special, unique actually, and had clinically OI type 1, 75%, and 25% had clinically OI type 3, 4, so the more severe types. Many of the participants were not genetic tested at the time, so it's clinically the severe type and the more mild to moderate type. And as you can see, the short form 36 has 4 subscales: mental health, role, emotional, social functioning, vitality, general health, bodily pain, physical functioning, and role physical. And if we move on, we compared the OI population with the general population, and as expected, of course, the OI population had significantly lower scores on all subscores under physical health. But there were not significant differences between the general population and the OI population in the mental health subscores. And then, in the next slide, we compared OI type 1 with OI type 3, 4. And when we compared OI type 1 with the more severe types, we found that those with moderate to severe OI have a better score on all subcategories, except for social and physical functioning. And I'm going to say a few more words about that later on when we are going to describe how to measure pain. I can see that there is a lot of questions coming up. Are we going to deal with them afterwards?
Yeah, we could do them afterwards. Yeah.
Yeah, because I'm concentrating on the presentation. I can't see the questions, but I see that they pop up. So
No
just stop
worries.
me if you're going to take some of the questions before the end. That's possible as well. Then we can go to the next one. You can have pain all over. You can have pain in one place, in 2 places. You can have referred pain, and you can have all sort of combinations. And I think we are now going into the more medical world, and something next slide, please. Something we often see is that symptoms and signs are often presented together, but it is important to keep in mind the difference, I think. A symptom is a manifestation of disease apparent to the patient himself, while a sign, like picture 2 here, is a manifestation of disease that the physician perceives. And the sign is objective evidence of disease. A symptom, like pain and fatigue, is subjective. And the process of identifying a disease, condition, or injury is based on the signs and symptoms a patient is having and the patient's health history and physical exam. And when we are dealing with pain, I think we have to look into a lot of questions that should be answered. If we look at the next slide, you can just put everything in there, I think. We can have to look at visible versus invisible disabilities, because what we saw in the Norwegian study, where you saw that the score of the persons with OI type 1 or the more mild ones had a lower score than OI type 3 and 4. And most of them have invisible disabilities, especially when they have their clothes on. But what we saw was that when they passed about 45 years of age, they lost a lot of function. They had tried all their lives to be full-time workers. They had family, they did everything. But then from 45 years of age and older, they started to lose more function. And then we are also talking quite often in Norway about is OI type 1 more moderate than mild due to all the other connective tissue issues that you get. We also have to look at other complications. Are there any soft issues? Does the pain correlate with the severity of OI? Is it chronic? Is it acute? The characteristics of the pain, comorbidity, and so on. And I think we can have a lot of questions that we have to go through together with the patients. If we move further, to assess the pain, it is important, of course, to get the picture of what type of pain we are talking about, but try not to think too complicated. I think we have a lot of tools and more tools are coming, but the easiest is still often the best. So using a simple scheme to map the pain, to have some questions about the pain intensity during activity and rest, use a VAS scale from 1 to 10 or smiling faces or something like that. Describe characteristics of the pain, anything that relieves the pain and anything that worsens the pain. And then give some characteristics like in the next slide. If it's dull, itching, throbbing in your joints, bones, or muscles, that is the most common description, regardless of the intensity of pain. And then if you have pain all over your body from nowhere specific, it's the main description when they have moderate pain. And then you have more distinct burning, stinging, numbness, tingling, pricking from a specific area that is coming when the pain is defined as mild, but also the more neuropathic pain, I think. The most common pain in OI is, of course, musculoskeletal pain. And it's a challenge to find a relevant tool to describe this musculoskeletal pain. And this article from 2024 evaluate usability of the Nordic Musculoskeletal Questionnaire to identify or evaluate the usability to identify painful sites in adults with OI and to describe the occurrence of musculoskeletal pain and its impact on their work and daily activities. And we also made a special version where we include some OI-specific questions like OI severity, OI type, and so on. And then we made a OI NMQ tool. And we found in a small group that it was feasible in assessing musculoskeletal pain among adults with OI, and it displayed a high prevalence of musculoskeletal pain, however, with a moderate impact on their regular work and daily activities. But we need larger studies, and I think Dr. Folkestad is going to start something, I hope, together with the rest of the Nordic group, to try to use this NMQ, OI NMQ scheme or more people to see if it can be valid. Next slide, please. We will always need a lot of individual information to give the best follow-up and treatment, of course. And symptom signs and functional status should be described in everyone to try to find also the etiology behind the pain. And also the nutritional status. If we go further, as both articles and the impact studies show, pain and often musculoskeletal pain and fatigue are the most common reported symptoms in OI, both across age groups and across severity. But behind the symptoms, however, they can hide medical conditions and complications from some of the many organs that may be affected by OI, which is the connective tissue disorders. And I wonder if the collagen changes could be to blame. If we go further, we do not have to forget the referred pain and comorbidity. If we, for example, look at musculoskeletal pain, which is most common, but it might be due to hypermobility, ruptures of the tendons and muscles, decreased muscle strength, and so on. But it can also be secondary to fractures as a result of fault loading over time, for example. It can be secondary to reduced sight. You don't know that you don't see so good anymore, and you concentrate a lot, and you get a lot of musculoskeletal pain. It might be due to deformities in the spine or to lung disorders, and so on. So I think we have to take into consideration that the connective tissue disorder may have different etiology to the pain. In the impact study, 35% of the participants reported, for example, gastrointestinal problems. And I think you have to take several aspects into consideration. For example, look at the body proportions. People with OI, especially OI type 1, often have a short torso. So how is the place of the gastrointestinal tract? Or is it the connective tissue issues because of reduced motility in the intestine? Is that why you get obstipated or get gastrointestinal pain or problems? Then we have some orthopedic issues that I'm going to talk a bit more about. Or it can be diet and activity or inactivity, actually. Gastrointestinal pain can also be referred pain from lungs and heart. And if we go to the next one, that protrusion acetabuli, and perhaps Dr. Franzoni should have told it, but it's a rare anatomic pattern of the hip in which the femoral head protrudes into the true pelvis. But the first symptom might be abdominal pain or chronic constipation. And when we meet somebody who has quite characteristic pain and we say you have to take an x-ray of your pelvis because of the gastrointestinal problems, that sounds a bit special, but it might be the etiology behind the pain. And the pain, if you have the pain at the level of entire gastrointestinal tract, it might also be fractures in the spine or in the ribs. So we have to be creative, I think, when we are looking at OI and pain. I would like to give an example of how a similar pain pattern can have two completely different causes. And this is two men who came to our skeletal dysplasia outpatient clinic. One was a man 34 years old with OI type 1. He had musculoskeletal pain in the neck, shoulders, and the spine for more than 3 months. He was often tired and needed to relax after a day at work. The other one was a man 38 years old, also OI type 1, musculoskeletal pain in the neck, shoulders, and the spine for more than 3 months, increasing fatigue, difficult to concentrate at work. Both of them have musculoskeletal pain. They have a lot of fatigue. They need to relax. Should we give them painkillers, or should we try to find what is the etiology? What is behind this pain? And then if we go to the first one, he had tight neck, tight shoulders, and upper back pain, and it was getting worse. But then we went through the checklist, and we saw that he has an increased hearing loss bilaterally. He had never done an audiometry, but he needed hearing aids. And after getting the hearing aids, of course, it was also easier to relax. And he was a teacher, so he was concentrating all the time. And then we have the other one. He did also have a tight neck, tight shoulders, and upper back pain. But when we did the spirometry, he had significantly reduced pulmonary function, and the X-ray of the spine showed 3 thoracic compression fractures, and he didn't know about it. So musculoskeletal pain is not only musculoskeletal pain. That is what we have to deal with. Next one, please. So in order to be able to prevent pain, fatigue, and various medical complications as much as possible, good and regular follow-up is important. And TRS has therefore prepared a checklist that adults with OI can use in collaboration with their GP. And this has been developed on the basis of studies that we have on adults from Norway, Denmark, and now also from a lot of other countries. And it's easy to follow, and it's dynamic. So if we find something new that we should include, we can do that. But then they have the possibility to make an appointment, go through it together with the GP, and they see that, oh, it's 3 years since you had an audiometry last time. Let's do it again. Or do you have any function loss that we should look into? What about the lungs, and so on? And then they can help each other to go through it. Because when you become more than 18 years of age, you have to go to the different doctors, and that's not easy. Like the pediatricians see a more, do it more holistic. When you are 18, you have to visit. The good transition. But I think the checklist is helping. So in what I try to say is that I do not think that we can talk about OI pain, or that pain is caused by OI. Pain can be a symptom of an event or a condition, which in turn may be related to OI. For example, pain due to a fracture, due to restrictive lung function, and so on. And prevention of medical complications and loss of function. So no matter how much we learn about genes, signs, and symptoms in OI, the follow-up routines and treatment of pain must always be based on each individual's starting point, physical, psychological, and social. And we need to have a holistic approach, and collaboration is, of course, a must, I think. So that's it. And since I represent the rehabilitation hospital, rehabilitation in OI should take all of this into consideration. And that's perhaps another lecture, how we can deal with that. So, a taste. Thank you.